Activities of daily living. Basically, we have eating, dressing, bathing, transferring, toileting, and bed mobility. Anything that has to do with our activities that we do every day. Brushing our teeth, eating, drinking, going to the bathroom, transferring from one place to another. Anything that we do for the patient is considered our ADLs. We focus on the 4 late lost ADLs because we're talking about the geriatric community later in life, so we're focusing on 4. Bed mobility, transferring, eating, and toileting. Let's start with bed mobility. Bed mobility is only things related to things that are done in the bed. If you're transferring a patient to the bed or out of the bed, from the bed, not considered bed mobility. The only thing that's considered bed mobility is things that are done in the bed. If you put a pillow behind the patient's head.
She came in, she saw it.
Okay.
Oh.
If you move the patient's head in the bed, if you lift his legs over a pillow to raise his legs in the bed, if a patient's elbow gets stuck in a railing and you push it in, something done in the bed, that's called bed mobility. Anything that's done in the bed. Transferring is from one surface to another, to and from bed, chair, wheelchair, from a standing position, from a wheelchair to the scale. The only time it's not considered transfer is when you're transferring to the bathroom, okay? Transferring to the bathroom is considered toileting. Anything to complete the action of toileting is considered toileting. So if I take a patient from the dining room all the way to the bathroom, not considered transfer, considered toileting, okay? We have to remember that. Toileting, anything that completes the action of toileting. So it can be anything in the bathroom itself, a commode that's outside the bathroom, a bedpan, a urinal, the chucks that we change, the clothes, unfortunately, that sometimes get soiled. Do you have ostomy and colostomy in your floor? Sometimes. So ostomy and colostomy, because that's how they're voiding. Anything to complete the action of the bathroom or toileting. So basically, when you have a chart, when you're charting the ADL, you have at the bottom of the chart, there's 2 parts. There's the self-performance that we do, and there's the residence performance that the residence does, right? So let's start with the self-performance. Let's start with what the resident does. It goes on a scale from 1 till 8. So it's from 0, 1, 2, 3, 4, and then 8. Okay. The way you chart it in your thing. Remember, there's I, S, L, E, and then T for total, and then X, which basically you don't use here, but the action wasn't done. Legally the way it's charted is the numbers that are on the side, 0, 1, 2, 3, 4, and then 8. But if you take the pen and you circle the first letter, I, S, L, E, T, that's where you get the first letter of what we're charting for. So let's start with independent. Independent is basically a resident that's not going to be here, but someone who is totally independent. I don't even have to watch him. He doesn't even need eye contact with that. Doesn't need any help. I don't have to supervise. I don't have to do anything for him. Totally, totally independent. Now, a patient who's coming from the hospital with the hip replacement, apparently they're coming here because they need help, because they need supervision, so that wouldn't even be considered independent, okay? Supervision would be eye contact. I'm sitting here, I'm watching a patient all the way down at that table. He doesn't know that I'm watching him, but he has a choking hazard. He is a choking hazard. I keep my eye on him, I'm watching him, that would be considered supervision. My hands aren't touching, it's too far, but I know I have eye contact with him, I'm watching. Okay, that's already supervision.
So you would put S1.
Correct. Okay? Limited assistance is any time I even have a pinky on the patient. Any physical contact. The patient is totally independent. He's standing at the toilet, he's voiding by himself, but I'm watching him and he's a little unstable. All I do is I take my 2 fingers and I hold his shoulders, right? He's standing alone. Really, it could be independent or even supervision, but I touched him. I'm not lifting him, I'm not helping him. I'm just holding him with my 2 fingers. That would be considered limited assistance, anything to guide or to maneuver. If a patient's sitting at a table and I'm feeding another patient at the same table, and I'm watching the patient and he's shaking and he's not getting his spoon to his mouth and he's unfortunately shaking, all I do is I gently guide his hand to his mouth. I'm guiding, I'm not doing anything, but there's physical contact there. That's limited assistance.
L1? L1.
Correct,
Yeah.
right? Now, just keep in mind, anything with eating is one. How many mouths do we have? We have one mouth. Two people can't feed the same person. So automatically you see eating, you put one. It doesn't matter. It's impossible for two people to feed a person. The other person might, put support or whatever, but feeding, eating is one person automatically, okay? But gently guiding would be limited, one.
Suppose you set him up to eat.
Setting up is something else. We're going to get there in a minute. Okay, totally different. This is hands-on. I'm guiding his elbow into the thing. Okay? Extensive assistance. So if you look at it, extensive, we would think a lot, right? The E. But is this doing a lot of work? Could the paper stand in the ear without my assistance? Am I sweating? Is it hard for me? No, but I'm assisting, right? Without my hand, the paper would fall. That's extensive assistance. It doesn't mean a lot of work. It doesn't mean I have to work hard, but I have to be doing it, okay? So if again, physical assistance, it has to be a physical contact, and it has to be something that I'm doing. The way I remember it is, if my hands are down, right? We said if I'm helping the patient stand up, my hands are down this way, would be limited. If my hands are up, a patient puts her hand in my hand, right? Even to lift a drop, just to help her guide up, that would be already. My hand is up, that would be extensive, because without me, the patient's not getting up, okay? Now I have, okay, then total dependence. Even if a patient is totally, even if a patient is totally independent, running up and down the hallway, scaring everyone else, but he's incontinent, right? He voids in a diaper, we have to change him. So it's not independent, we can't put I, it's not S, we actually have to change him. So even though everything else he does is independent, for toileting, he's T. He's totally dependent on us to change him. Okay, and then the X would be someone who sleeps through your whole shift, which never happens. Someone who doesn't poop during your shift, which doesn't happen. But if something happens and it's not, then you can put the X or non-applicable.
It's on the truck. It's on the truck, yes.
Okay, now one more example that I had asked Steve when he taught me about this. If a patient is getting up in bed, got dressed alone, is totally independent. She says to me, honey, can you pass me the walker? And all I do is wheel her the walker and step away. She gets up on her own, and the next thing I know, she's in the hallway. What would that be?
That's limited.
No, that would not be. That would be support. That's what you said. Because all I'm doing is supporting her. I'm bringing her
Just
something.
give it to her.
But
So I thought that would be limited because you gave her the walker.
so that's set up. You're going to see that's another thing. But if I'm giving the patient a walker and I'm watching her and I'm watching the walker slide away from her. So all I do is I take my hip and I put it against the walker. Right? I'm not working hard, but without me the walker is running away. What would that be?
Support then.
No. Extensive.
That's extensive.
That's
because you're
extensive.
holding it to
Exactly.
keep it from
Without me, the
moving.
walker is rolling away. The patient can't get up. Okay, that would be already extensive. That brings us to the next thing of the support coding. That's what we do. So no setup, no physical support. The reason they're here is because they need our help. So we don't have that. One is the setup, help only. So if I have a patient who's eating independently, totally eating independently, but today she's not feeling well, she's very weak, she asks me, honey, can you please cut my chicken? I take her plate, I cut up the chicken, and I hand it back to her, and I walk away. That's called setup. Setup only. That's all I did. I didn't help her eat, I just cut it up for her. She's too weak to use the fork and knife.
See, everyone has their own thing.
But that's what they want from us. That's the coding that they want.
Because they said, okay, You gave the resident his or her, the patient,
Whatever.
his or her tray. And you give it to, you give it to them. And it's not supervised? No?
No, that would be set up. That would only be set up.
That's what I said too.
Right.
But then I was told that's supervised. No one is.
If I ask you, I'm independent, right? I can't reach that pencil. I say, Peggy, can you please pass me the pencil? You pass me the pencil and I take it from you. I'm independent. You're not supervising me.
Right, that's
You're
what I
just
said
setting me
too.
up. You're helping me,
That's me,
okay? That's set up.
Little one.
They told me that there's only one patient here like that. Someone, Robert, something. He basically, this is what I was told. I don't know the patients here that well.
Totally.
He can eat alone. You don't even have to watch him. You don't, like, maybe he would need to set up. I don't know the patients here, so whatever.
No, no, patient.
Okay. Then 2 would be one person physical. So again, for the eating or anything you do alone, or the supervising, like someone said here. And then 2 persons would be the physical assistants when you're actually taking the draw sheet underneath the patient and lifting him further up in bed. That would be 2. Now, the second you see Hoyer lift automatically requires 2 people. Don't even think about it. Even if you physically can do it alone and the patient is very small, legally, a Hoyer lift is 2 people. Don't even think. You see Hoyer lift, put down 2. You see eating mouth, you put down 1. Okay, now I just have another few rules and then we're done. You have to code what the patient actually did. Not what the patient could do, not what the patient should do, but what the patient actually did, okay? Code the most assistance you provided to the patient, which means if the patient can walk alone, but is so tired, just came back from a doctor's office, and asks you, please wheel me down the hallway. Is the patient independent? Yes, the patient is independent. But you once during that shift, helped him in the wheelchair, rolled him, that's already, you always document at the end of the shift the most severe, the most help you gave him during that shift, okay? And only, that brings us into the point where only document at the end of the day. Because if you document anywhere but, you might do something later on, and then you're not gonna go back, and then it's white out. Don't document in the middle of the shift, even if you say, I know this patient, he's a long-time resident, I know him already, blah, blah, blah. Every shift ends up being different. That's where we get our information from you. If there's a physical change, if there's a medication that needs to be readjusted or changed, if there's a psychiatric issue, like if the patient usually gets out of bed but is not getting out of bed, maybe it's depression, maybe the social workers have to get involved. The only way we get information about the patients is through your documentation. And the last thing, there's this thing called the copycat syndrome. What happens is I see T2, 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 T2. All right, that's probably what he did today. I'm going to write T2, 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 T2. If I see S1, 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 I know this patient. It's definitely S1, 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 S1. I don't even think. But that patient has a urinary tract infection, is not doing as much, and needed total care. How am I going to find that out as a nurse? How to help them, or how to adjust them, their medication, or how to give them antibiotic if I don't get documentation from you? So that's why the ADL documentation is so important to keep our facility running. And the last thing I just wanted to end with is anything you document, anything that we want to get money for, anything that we want to